Welcome to our 2010 presentation on endocarditis. Hold on because it is a really cool world. We have some great slides coming up. And since we are in the process of building our toolboxes when it comes to recognizing the different normal and abnormal sounds, slide 10 has an audio of what a heart sounds like when infected with endocarditis. An overgrowth of bacteria that colonizes mainly on the mitral valve and the heart, but can also affect the tricuspid valve. The colonization of bacteria occurs along the edges of the heart valves. Agglutinating antibodies produced by the bacteria hold vegetation masses onto the affected valve. This causes the inflammation to continue building even more vegetation, leading to an erosion or perforation of the valve cuspid, leading to even more damage. Another way to see this is when a child drops a piece of candy on the ground and it is left there, you will see a trail of ants going to the candy and also covering it. This is sort of like a Sesame Street view of what the colonization of bacteria look like. Some of the risk factors are having prior endocarditis, prosthetic heart valves and acquired valve disease, cardiac lesions, rheumatic and congenital heart disease, pacemakers, Marfan syndrome and cardiomyopathy, hospital-acquired bacteremia, and IV drug abuse. There are numerous procedure-associated risks. Prophylactic treatment is used in hopes of preventing endocarditis in certain patients undergoing certain procedures. Some of these include prosthetic heart valve or repair of heart valve, cardiac transplants, oral procedures involving tooth extractions or the puncture of oral mucosa, respiratory biopsies, tonsillectomies, and adenoidectomies. GI and GU, the wound infections, and UTIs. If you remember when we were in clinicals, we had to do a PICC line dressing under sterile procedures, and this is one of the reasons why, to prevent endocarditis. This slide shows the beautiful world of inflammation when it's building vegetation. There's a risk of vegetation sloughing off and becoming an emboli. Now, the left side, they're going to experience systemic embolizations. The right side, they're going to experience pulmonary emboli. That is, if the vegetation sloughs off. This is why it's so important to know if your patient has right-sided or left-sided vegetation. It's very important to know which side of the garden the veggies are growing on. The geek in me just had to include this slide. It's just a really cool histology slide.
Like with most infections, symptoms can be very generalized and nonspecific. Some clinical manifestations are low-grade fever, chills, weakness, malaise, fatigue, edema, arthralgia, weight loss, headache, night sweats, back pain, abdominal discomfort. These are all pretty much subjective. It means, when the patient will come in and they're just not feeling well. They've got one or more of these symptoms. They don't know what to do about it. Nothing's really helping. And so they come into the clinic or wherever, and what's needed is some diagnostic tests such as blood work to figure out what's going on. A vascular manifestation of endocarditis are splinter hemorrhages on the nail beds, Roth spots, pedicaya, Janeway's lesions, and Osler's nodes. I'm just going to go over 3 of them. Splinter hemorrhages are these little black lines on the nail beds and usually asymptomatic. Roth spots are retinal hemorrhages. You can find them in the eyes of the patient. Osler's nodes are really painful. They're raised lesions found on the hands and feet. pretty obvious signs, and really these are quite objective, because when you see these, you know that the sign point to endocarditis. Like with all nursing, we love mnemonics. And if you're studying endocarditis, one of the best mnemonics for it is from Jane. Fever, Rothspot, Osler nodes, murmur, Janeway's lesions, anemia, nail bed, and emboli. We love mnemonics in nursing. Lab findings and medication treatments. Lab tests are to determine leukocytosis, anemia, and other blood issues. Cultures determine the causative organisms, and sensitivity tests indicate the antibiotic needed to combat the infection. 2 blood cultures are drawn from 2 different sites within 30 minutes of each other. And if a patient has endocarditis, the results will be like 90% positive. There will be increased white blood cells, of course, because of the infection. And the medications to treat endocarditis are penicillins and antibiotics, depending on what the sensitivity test comes back as. That's really the first line treatment is antibiotics. Collaborative care requires interprofessional communication and is the cornerstone of all healthcare-related successful patient outcomes.
Collaborative care, diagnostic studies. 2 blood cultures drawn 30 minutes apart from 2 different sites. Echocardiography, transesophageal echocardiogram, 2 or 3 dimensional transthoracic echocardiogram, chest x-ray, electrocardiogram, and cardiac catheterization. The initial treatment for infectious endocarditis is hospitalization, IV antibiotic therapy. Antibiotic is based off the blood culture results. Fungal endocarditis and PVE respond poorly to antibiotic therapy alone. Early valve replacement and 6 weeks or more of antibiotic therapy is typically required. Fever may persist for several days and can be treated with aspirin, Tylenol, or ibuprofen, fluids, and rest. Long-term treatment is necessary to kill dormant bacteria within the valvular vegetations and generally take weeks, and relapses are common. Home care after hospital discharge includes IV antibiotic therapy, vigilant home nursing care, bed rest to moderate activity, good nutrition, and avoid anyone with infections, especially respiratory infections. Conditions requiring prophylactic treatment prior to having a procedure is a prosthetic heart valve, previous history of infectious endocarditis, congenital heart disease, and cardiac transplant recipient who developed heart valve disease. Procedures that require prophylactic treatment are dental manipulation, including gums, roots, puncture of oral mucosa, extractions or implants, respiratory tract incisions, tonsillectomy or adenoidectomy, gastrointestinal and genitourinary wound infections or urinary tract infections.
The nursing diagnosis for clinical manifestations of endocarditis. Using the nursing process of ADPI, assessment, diagnosis, planning, implementation, and evaluation, diagnosing allows the nurse to tie in the initial assessment, and that's where they get to form a judgment about the patient's issues, what the patient needs, and using critical reasoning, it is also a way for the nurse to analyze the client to set them up for recovery. Activity intolerance related to less oxygen supply caused by decreased cardiac output. This nursing diagnosis helps the care team understand the needs of the patient, either by providing supplementary oxygen or assisting the patient to mobilize. If the patient is hospitalized, what's indicated is to make sure that you're monitoring O2 sats, respirations, and BP, and to teach the patient to stop any activity that they're doing if there's any form of breathlessness. Decreased cardiac output related to inflammation of lining of heart and change in structure of valve leaflets. So with this, because the heart isn't pumping as well as it should, one of the things that's indicated is to make sure you're monitoring the fluid intake and measuring the intake and output of your patient. This is because, with decreased perfusion, there's a fluid overload is possible. So IV monitoring, and they're probably going to be on restriction anyways, but the good patient teaching would include telling your patient not to have too much sodium. If they smoke, tell them to stop smoking, and teach them forms of stress reduction, such as breathing techniques and guided imagery. Risk for imbalanced nutrition related to hypermetabolic state associated with night sweats. So the hypermetabolic state includes the fact that the heart is working kind of overtime. Even though it's decreasing in output, it's trying not to. It's working really hard. And so what will happen is the patients will start to lose weight, and night sweats is part of that. So I think that once a patient starts to lose weight, it happens sort of rapidly. And one of the teachings that you can offer your patients is to eat a high-protein diet and also create a journal so that you can assess what it is that they're eating, so that maybe you can help guide them even further. Disturbed body image related to obvious clinical manifestations such as splinter hemorrhages, Osler's nodes, and Roth spots, as evidenced by a congruence between body reality, body ideal, and body presentation. I feel that if there is a patient who really takes pride in their appearance, these obvious and visible symptoms and signs of a disease process may make it difficult for the patient through their healing process. One of the teachings that you can include is support and education on the fact that these symptoms and clinical manifestations will go away through treatment, and that they won't always have them.
So as you can see, most of these potential complications are related to embolized bacteria, such as stroke, sepsis, and periannular abscesses. The other two are heart failure and cardiac tamponade, and this is related to the increased workload as well as the stroke volume because of the vegetated bacteria that's on the heart. It causes it to work much, much harder than it should be. So the best way at preventing these complications is to treat the endocarditis very promptly. Most of the time this is treated with antibiotics. However, sometimes depending on the severity of the vegetation in the heart, you do require surgery to treat this endocarditis. As you noticed from the last slide, almost all of the complications are a result of the bacteria embolizing and not being treated properly.
This presentation was brought to you by Cassandra, Jaleesa, Krista, Leah, and Natalie. We're all third-term nursing students, and we look forward to continuing our education. Thank you for watching. And this is the reference page. Thanks again for watching.